When you hear a difficult medical diagnosis, it can feel like the world just tilts. Everything changes in an instant.
Yeah, the air gets thin, sounds might seem muffled.
Exactly. And that future you had all mapped out, suddenly it vanishes into this fog of uncertainty and, frankly, fear. And for you, the caregiver, it's like a double whammy, isn't it? You're dealing with your own shock, your own grief.
Right.
But at the same time, everyone's looking to you to be the rock, the steady one.
It's an incredibly tough spot. Disorienting is a good word for it.
Yeah.
And in those first moments, fear really thrives in the unknown. Suddenly you're just inundated with all this new information, these intimidating medical terms.
Overwhelming.
Completely. So our mission here in this deep dive is really to cut through that. We want to give you the most powerful tool you can have in those first days, which is knowledge.
That's it. Because it often feels like you're trying to learn a whole new language, right? This doctor speak. And it can feel like a barrier at first, maybe even intentionally confusing, but it's actually about precision.
Exactly. Doctors use these specific terms to be absolutely exact. No room for confusion on their end.
So our goal today isn't, to make you an oncologist overnight.
No, not at all.
But it is to help you understand that language, to empower you so you can be an informed, confident advocate for your loved one. We've pulled the key insights from Decoding Cancer, a caregiver's first 30 days, to help do just that.
To clear that path a bit.
Okay, let's dive in then. Let's cut through some of that initial confusion and start building that foundation. It really starts with the language itself, doesn't it? Turning that doctor speak into something understandable.
It does. That's the first step towards feeling more in control.
So what are those first absolutely essential words a caregiver needs to get a handle on?
Okay. Let's start with the very first things you might hear when, say, an abnormal growth shows up on a scan. You'll hear words like tumor, mass, nodule, maybe lesion. These are often used pretty interchangeably. They all just mean an abnormal growth of cells.
Okay.
Now, here's the first really vital thing to grasp, and it's huge for managing that initial panic. Hearing tumor or mass does not automatically mean cancer.
That's huge. Just hearing that distinction must offer some immediate relief.
It really can.
Yeah.
Because the word tumor itself carries so much weight, right?
Yeah.
It instantly brings cancer to mind for most people.
Absolutely.
So just knowing that difference, abnormal growth versus cancerous growth, gives you a little bit of ground back. It shifts things, even if just slightly, from pure fear to a more, grounded understanding, even if you're still anxious.
Makes sense.
And this leads us straight to the crucial difference between benign and malignant.
Okay.
Benign. That's the word you're really hoping to hear. A benign tumor is not cancerous. It might grow, sure, but it won't invade nearby tissues or spread to other parts of the body.
So it stays put.
Exactly. They're often removed, and usually they don't come back. Malignant, though. That's the word for cancer. Malignant cells have abnormal DNA. They multiply without control, and crucially, they have the ability to invade the tissue around them. And they can also travel through the blood or the lymphatic system to other parts of the body.
So it's that ability to invade and spread that's the defining characteristic of malignancy.
Precisely. It's not just the growth. It's aggressive potential.
And to know for sure whether it has that potential, a doctor needs more than just a picture, an image.
Absolutely. That's where the biopsy comes in.
Yeah.
It is the critical step for a definitive diagnosis.
Okay. The biopsy.
It involves taking a small sample of tissue from that abnormal area.
Right.
That sample then goes to a specialist, a pathologist, who examines the cells under a microscope. And honestly, there is no way to be 100% certain about cancer without that biopsy. It's the gold standard.
Got it. No biopsy, no certainty.
Pretty much.
And just understanding those few initial words, tumor, benign, malignant, biopsy, it really does shift your perspective, doesn't it?
It absolutely does.
You go from being this passive listener, just hearing scary sounds, to someone who can actually start to engage with the information. You understand what they're looking for.
You start to decode the process.
So we've got a handle on what it might be. Now, let's talk about where it is and how much of it there is. This is where the bigger picture starts coming together, right? Leading towards treatment.
Indeed. This is where we build the roadmap. First, you'll likely hear about the primary site.
Okay.
That's just the original spot in the body where the cancer first started. So if it starts in the lung, it's primary lung cancer. Simple enough.
Makes sense.
Then there's the term metastasis, or metastatic cancer. This is often the really feared word.
Yeah.
It means the cancer has spread from that primary site to another part of the body.
Right.
But here's a really, really crucial point that often gets misunderstood. If lung cancer spreads to the liver, it is not now liver cancer.
Ah, okay. That's counterintuitive.
It is. It's still metastatic lung cancer in the liver. And this isn't just, splitting hairs with terminology.
It matters for treatment.
Hugely. It dictates the entire treatment plan. You treat the original type of cancer cell, not the location where it ended up.
Wow. That's such a critical distinction. I imagine many people assume it becomes, like you said, liver cancer in that example.
That's a very common misconception and totally understandable. People think, oh, it's in the liver now, so we treat liver cancer. But no, the cells keep their original identity.
Okay.
Understanding that one point can make a huge difference in comprehending why certain treatments are chosen.
Yeah, I can see that.
And this leads us directly into staging.
The roadmap you mentioned.
Exactly. Staging is the process doctors use to figure out how much cancer is in the body and exactly where it is. It's probably the single most important factor in planning treatment.
Okay. And how do they determine the stage?
It's usually a combination of things. The physical exam, those imaging tests like CT scans or PET scans we mentioned, and of course the biopsy results.
And staging has its own language too, right? The TNM system.
That's right. The TNM system is the most common one. It breaks down like this. T is for the primary tumor. It describes its size and how far it's grown into nearby tissue.
T for tumor. Got it.
N is for nodes, lymph nodes. Specifically, it tells you if the cancer has spread to nearby lymph nodes, which are part of the body's filtering system.
N for nodes.
And M's for metastasis. Has the cancer spread to distant parts of the body?
T and M, tumor, nodes, metastasis.
Correct. And based on the T and M findings, the cancer is usually assigned a stage number.
Okay.
Generally, it goes from stage 0 up to stage 4.
Okay. What do those mean broadly?
Broadly speaking, stage 0 means you have abnormal cells, but they haven't spread, sometimes called in situ. Stages I, E, A, E, A generally mean the cancer is larger or has spread into nearby tissues or lymph nodes. The higher the number, the more extensive it usually is.
Okay.
And stage 4 means the cancer has metastasized to distant parts of the body, like our lung cancer in the liver example.
Right.
But it's really important to remember the specifics vary a lot depending on the type of cancer. Stage 2 breast cancer is different from stage 2 colon cancer.
Understood. It's not universal across all cancers.
Not precisely, no.
So staging tells us where and how much, but then there's also the grade. How is that different?
Good question. While staging is about location and spread, grade is about how the cancer cells look under the microscope.
Ah, the appearance.
Exactly. The pathologist looks at how abnormal the cells appear compared to healthy cells. Low-grade cancer cells look more like normal cells and usually grow slowly.
Okay.
High-grade cancer cells look very abnormal, very different from normal cells, and they tend to grow and spread more quickly. So grade gives you an idea of the cancer's aggressiveness.
Right, how fast it might move.
Potentially, yes. Then you might also hear the term prognosis.
The outlook.
It's essentially, yes.
Yeah.
It's the predicted course of the disease. The oncologist uses it to give an idea of the likely outcome, maybe how effective treatments might be.
But it's not set in stone, right?
Absolutely not. And this is so important. A prognosis is an educated guess. It's based on data from large groups of patients. It is not a guarantee or a deadline. Every single person is unique.
That feels crucial for managing hope and expectations. It's easy to latch onto a statistic as a definite timeline, isn't it?
It is. It's human nature to want certainty. But caregivers can really help by gently reminding everyone, including themselves, that these are statistical likelihoods, not personal guarantees. It's about understanding the terrain, not predicting the exact path.
Okay. And what about terms related to outcomes, like remission?
Right. Remission is definitely a hopeful word. It means the signs and symptoms of cancer have decreased or disappeared. You might hear complete remission, all signs are gone, or partial remission. The cancer has shrunk but is still there. But importantly, it's not the same as cured.
Still needs monitoring.
Definitely. And unfortunately, the flip side is recurrence. That means the cancer has come back after being in remission. It could be local, regional, or distant.
Okay. So, bringing all these terms together, primary site, metastasis, staging, grade, prognosis, remission, recurrence, it paints a really detailed picture, doesn't it?
It really does. Understanding these gives you, the caregiver, a much clearer view of the situation, the nature of the disease, its extent. It's the foundation for understanding everything that comes next, especially the treatment plan.
Okay, so with that foundational vocabulary starting to make sense, let's pivot to something you touched on, how care can be really different depending on the patient's age, specifically for older adults.
Yes, this is a critical point. Treating cancer in older adults isn't just about adjusting dosages. It's often a fundamentally different approach.
Why is that?
Well, you're not just treating the cancer. You're caring for a whole person who has lived a long life, accumulated experiences, and often other health issues.
Right, they likely have other things going on. What's the medical term for that?
That brings us to comorbidities.
Yeah.
That just means other health conditions the person has besides the cancer, things like heart disease, diabetes, maybe arthritis, lung issues.
And those matter because
They significantly impact which cancer treatments are safe and how well the person might tolerate them. A chemotherapy that's tough on the heart might be too risky for someone with pre-existing heart disease, for example.
Makes sense. You have to weigh the risks and benefits differently.
Exactly. And another key concept here is frailty.
Frailty. What does that mean in a medical context? It's not just feeling a bit weak.
No, it's more specific than that. It's a recognized medical state of increased vulnerability, sort of a reduced resilience to stressors.
Okay.
So a frail, older adult might really struggle to bounce back from the physical stress of chemo or major surgery. Assessing frailty is really key to tailoring the treatment.
So it's about this bigger picture, the whole person's health status.
Precisely. Which leads to something called a geriatric assessment.
What does that involve?
It's a really comprehensive evaluation. It goes way beyond just the cancer. It looks at their physical function, can they walk easily, get dressed? It looks at their cognition, memory, thinking skills, emotional health, nutrition, their social support system.
Wow, really holistic.
Very. It gives the care team a much richer understanding of what the patient can realistically tolerate and what kind of support they'll need. It's about fitting the treatment to the person, not just the disease.
And taking that holistic view must bring up some really important, sometimes difficult conversations, especially around quality of life versus quantity of life.
Absolutely.
Yeah.
That often becomes the central conversation. For many older adults, the most aggressive treatment isn't necessarily the best treatment for them.
Right?
Their priority might be less about adding months or years at any cost, and more about maintaining their independence, managing symptoms, and enjoying the time they have with family.
It's a deeply personal calculation.
It is. And the source material really emphasizes that the caregiver's role here is often to help amplify the voice of their loved one, to make sure their priorities and values are heard and respected in those decisions.
That really drives home how individualized cancer care needs to be, especially for older patients. It challenges that idea that there's one right way to treat cancer.
Completely. It's about aligning the medical plan with the person's life goals.
Okay, so once the diagnosis is clear, the staging is done, and the patient's overall health is considered, what are the main tools in the oncologist's toolkit? And who are the key people involved?
Right. Let's touch on the main treatments you'll hear about. There's chemotherapy, which uses powerful drugs, often given intravenously or as pills, to kill fast-growing cells anywhere in the body. Think of it as a systemic treatment.
Okay, widespread.
Then there's radiation therapy. This uses high-energy rays, like X-rays, precisely aimed to destroy cancer cells in a specific targeted area, more localized.
Got it. Chemosystemic, radiation local?
Generally, yes. Then we have newer approaches. Immunotherapy is a really exciting field. It basically works by harnessing the patient's own immune system to recognize and attack the cancer cells.
Training the body's defenses.
Kind of, yeah. And targeted therapy. These are drugs designed to attack specific molecular targets, often genetic abnormalities found on or in cancer cells. Because they're more targeted, they sometimes have fewer side effects on normal cells compared to traditional chemo.
More precise.
Exactly.
And then there's a term you mentioned is often misunderstood. Palliative care. Let's clarify that again because it seems so important.
Yes, absolutely crucial. Let's be really clear. Palliative care is not hospice. It is not just end-of-life care.
Okay, so what is it?
It's specialized medical care focused on providing relief from the symptoms, pain, and stress of a serious illness, whatever the prognosis. The goal is to improve quality of life for both the patient and the family.
And it can be given alongside other treatments?
Yes, that's the key message. It can and absolutely should be offered right for the beginning of a serious diagnosis. Alongside curative treatments like chemo or radiation, it's about managing symptoms and stress throughout the journey.
That's such an important clarification. It's about support, not giving up.
Precisely. Symptom management, communication support, helping with difficult decisions.
Okay. So who are the main players on this care team that a caregiver will interact with?
Well, the central figure is usually the oncologist, the cancer doctor. There are different types. The medical oncologist usually manages chemo, immunotherapy, targeted therapy,
Right.
they're often the main coordinator.
Okay.
You also have surgical oncologists who perform operations to remove tumors, and radiation oncologists who oversee radiation treatments.
Right.
And don't forget the person who made the diagnosis in the first place, the pathologist. They're the detectives examining the tissue, figuring out the type, the grade, providing that essential roadmap for the oncologists.
Behind the scenes, but critical.
Absolutely. And then there's the palliative care specialist we just talked about. Could be a doctor or a nurse practitioner, specially trained in symptom management and supportive care.
It really takes a village, doesn't it? A whole multidisciplinary team.
It really does. No one fights this alone.
Okay, listening to all this, it's easy to see how someone, especially in those first few weeks, could feel like they're just drowning in information. Drinking from a fire hose, as they say.
It's completely overwhelming. The volume of new information plus the emotional weight. It's immense.
So how does a caregiver shift from just trying to survive that onslaught to actually using that information? How do they become that active, empowered partner we talked about?
The source, Decoding Cancer, gives some really practical, concrete advice here. First step, get a notebook.
A dedicated cancer notebook.
Yes, and bring it to every single appointment. No exceptions.
What goes in it?
Everything. Write down the terms you hear, even if you don't know what they mean yet. Write down your questions before you go to the appointment. That's key.
So you don't forget in the moment.
Exactly. When you're stressed or emotional, things fly out of your head. And write down the answers you get, even if you need to look them up later. Just capture it.
Good tip. What else?
Ask permission to record the conversation on your phone. Politely, of course. Would you mind if I recorded this so I can review it later?
And doctors are usually okay with that.
Most are very understanding. It helps ensure you both recall the conversation accurately, and it lets you absorb things at your own pace later on.
That makes sense. What if you're in the appointment and the doctor uses a word and your mind just goes blank? You don't want to seem like you're interrupting or being difficult.
You have to interrupt.
Yeah.
Politely but firmly. Just say something like, "I'm sorry, doctor, that's a new word for me. Could you explain what that means in simpler terms?"
Okay. It's okay to stop them.
It's more than okay. It's essential. This isn't about being difficult. It's about being a good caregiver. You are a vital part of the care team. You have to understand the plan to help implement it and support your loved one.
That reframes it completely. It's part of your role.
Absolutely. And the ultimate goal here, with all this, the notebook, the recording, asking questions, is to transform yourself. To go from feeling like a passive, maybe fearful bystander into an active, informed, empowered partner in your loved one's care. Grasping the language is the very first, most powerful step in taking back some measure of control in a situation that feels utterly out of control.
Taking back control. I love that. What a powerful way to frame it. Knowledge really is the key, isn't it? It's the tool that lets you navigate this incredibly challenging territory.
It truly is.
Yeah.
Understanding the language, the staging process, the treatment options, and especially that holistic view of the person, it changes everything. It empowers you to ask better questions, participate in decisions, and really advocate for what's best for your loved one.
Well, thank you so much for walking us through all of that. It feels incredibly valuable. Thank you for joining us on this deep dive into such critical and hopefully empowering knowledge.
My pleasure.
And as you, our listener, reflect on this, on understanding not just the medical facts, but also that crucial human dimension of care, here's something to think about. How might this newfound knowledge empower you not just to advocate for a loved one in a crisis, but maybe also inspire you to prioritize deeper, more holistic conversations about well-being in all parts of your life, even when things are calm? Something to mull over until next time.